a pioneering person in the field of pediatric or pulmonary artery hypertension, and he started the PVRI group in India.
Thank you. Good morning, everyone. As it is being set up, I should say I have never been a professor. It is a dream in my life. I could never become a professor. Probably I will not become a professor also, working in private practice. Thank you so much. Now, I thank the organizers for this talk. And I am an odd man out here. I am basically an adult cardiologist. Whenever I see a child as a patient, I get intimidated, challenged. So I don't consider children as what do I do? Well, I don't consider children as small adults. I am aware of it. And as I was preparing, I realized most of the talk related literature is from Professor Havath. So she is going to correct me and take all the questions. I'll be directing all the questions to Madam, and she'll be answering. Well, these children are dressed as Mahatma Gandhi, but we know they are not Mahatma Gandhis. As you know, pulmonary hypertension is a progressive disease. What we are doing is only looking at the vasomotor component of it. It is basically a proliferative disorder. It is a relentless proliferative disorder like a cancer. As the time goes on, the pulmonary vascular proliferation occurs and the pulmonary vascular resistance increases and pulmonary artery pressure increases. Pressure is a product of resistance and flow. As the resistance increases, the cardiac output decreases and the pulmonary pressure decreases. And cardiac output and pressure at a point of time may be less. In a very sick patient, decreasing pulmonary artery pressure does not mean that the patient is improving. Actually, it means that the patient is deteriorating. I suppose it's clear. This is important concept to understand. Now, the topic assigned to me is how do we reassess or look at these patients in follow-up? If I understood well, how are you going to follow these patients while they are on treatment? So whenever they come back, what do you do? The first and simplest thing, foremost important, is clinical. Then you look at the quality of life parameters. These patients typically limit their quality of parameters. If I can extrapolate from adult patient population, most of the women, sorry to say, no gender bias, above 50 years, they say they are doing well, but they seldom step out of their house. They are totally homebound. So when you decrease your activities, you think you are doing very well, good, but actually, objectively, you are not doing well. So it's very important to go into intricacies of the quality of life, then look at how they are doing. Then objective tests like ECG, echo, blood tests, functional assessment again has to be objective, and hemodynamics, we'll discuss about it, and consideration of further therapies, patient education, supportive care, all these are important while following these patients. In history, we talk about the functional class, and in children especially, growth is very important. And simple examination like pulse rate, a tachycardia tells you that the patient is not doing well. A low pulse pressure, there's something called pulse pressure index. If the pulse pressure upon the systolic blood pressure is less than 0.2, it means the cardiac output is likely to be less than 2 liters. Very simple parameter. If you see the low pulse pressure, that means the patient's cardiac output is low. And bedside examination, simple jugular venous pressure. Pulmonary hypertension doesn't always mean elevated jugular venous pressure. Jugular venous pressure is elevated when the right ventricle starts deteriorating. So the moment you start seeing a elevated jugular venous pressure, signs of right heart failure, a right ventricular S3 or pansystolic murmur of tricuspid regurgitation, then you know the patient is deteriorating. So it's very important to document the presence or absence of all these signs in your clinical notes so that you can compare later when and how the patient is deteriorating. this is the functional class is very important. All this functional class, all of us know, as from third year medical students, we know this, the functional class. There is slight modification between NOH and WHO classification, but I realized this is not useful or very relevant in children. This is probably most of you know it very well. Basically, it takes into account the functional class, to relate it to the children less than 5 years especially, what kind of activities they do, how sometimes because the severity of the symptoms, they have regression of the milestones and they don't like to play, they don't like to walk. They, depending on the suppose school going child, he may not be playing, he may not be keeping pace with the peer group. So while assessing functional class in children especially, you have to take this into consideration. It's a big slide. I'm sure most of you are aware of it. Otherwise, also you can see it, and one has to apply it in the day-to-day practice. Then changes in the ECGs are really not much when you are starting patient, but further increase in the right axis, increase in the right ventricular forces, a deepening S wave in one AVL and R wave in V1, or STT changes which have started appearing, they all indicate that the disease is progressing. And arrhythmias are fortunately uncommon unless the disease is very advanced. Then you see atrial fibrillation. At a time I was thinking 25, 30 years back that atrial fibrillation means it's not idiopathic pulmonary hypertension. But nowadays with the advent of therapy, we know atrial fibrillation can occur in idiopathic pulmonary hypertension. Then second easiest thing that we do in our practice is the echocardiogram. The most fundamental thing that you should know that the changes in peak TR velocity are not reliable marker of clinical response. This is very, very important. This is one of the common mistakes made by physicians, pediatricians, cardiologists, and pulmonologists, whoever is treating these patients. As I mentioned to you in one of the first slides, as the pulmonary vascular resistance increases, RV contractility decreases because of the afterload mismatch, the pressure starts decreasing. A decrease in pressure in the presence of severe right ventricular dysfunction does not mean that the patient is doing better. And as shown in a clinical trial in Bosentan, some of the slides that I am going to show, one of the trials on Bosentan about 16 weeks, they looked at the various parameters. Let us see what are the parameters that you should follow. Here, you should see the right ventricular dilatation, you should look at the hypokinesia, these are the parameters. IVC altered, that is eccentricity index. You can see in the slide here, you should look at this is the RV dilatation and RV end systolic area, one should note, RA end systolic area, one should note, the movement of the pushing of the intratracheal septum to the left side, and eccentricity index, you take the D1 upon D2, that will give the eccentricity index because the left ventricle is getting compressed and D-shaped, and of course IVC plethora. These are some of the parameters which will tell you how the patient is whether improving or deteriorating, and not right ventricular systolic pressure as assessed by TR jet velocity. So if you can see in this Bosentan trial, the patients, the RA size, when it is less than median, their survival is better than RA size more than median. Similarly, presence or absence of pericardial effusion, eccentricity index, and these are all the factors which tell you whether the patient is improving or deteriorating or maintaining status quo. And similarly, T index, the myocardial performance index, if it is increasing, the number is increasing, that means the person is deteriorating, the right ventricle is deteriorating. So this is another factor that you should see. So summarizing, when you are following these children, sick children on echocardiographically, you should of course look at the RV systolic pressure as TR jet velocity, but what is more important is look at the RV fractional area shortening, RV end systolic area, RA end systolic area, TAPS A, I am sure all of you know, I don't have to explain to this audience what is tricuspid peak systolic exertion, or TAPS V, tricuspid annular plane, septal velocity, the velocities of the myocardial velocities, T index, eccentricity index, and LV to RV size and their ratios. Right ventricular outflow tract velocity time integral, a sign of right ventricular output, and global strain and stroke work. These are the parameters that we should see, and it is better to have something like a table like this for each patient and follow them over a period of time, so you will know how exactly the child is progressing rather than a routine echocardiographic report that you may generate in your hospitals. And due to variable body size and differential causal pathophysiology, pediatric echocardiographic variables have specific reference ranges and a variable effect on the accuracy of diagnosis. So again, this is where the difference between the children, pediatric patients and adult patients come. We cannot automatically give the adult reference ranges to the children, and each child can work as his own control, and we should look at the trends in these patients when you are following the echocardiography. Another important thing that you do whenever the patient comes is the 6-minute walk test. Some time back, I think 2001 or 2002, when we were looking at the sildenafil in children study, the STAR trial, we used the cardiopulmonary exercise testing. The argument then was that 6-minute walk test is not reliable in children, which is not true. In children above 5 years, 6-minute walk test is very reliable and it can be reproducible, consistent. And it's very simple measure of functional performance and correlates well with the survival and functional class and how the patient is progressing. And it is easily applicable and does not require any expensive equipment. I don't think more than 4, 5 or half a dozen centers in India are there who have the cardiopulmonary exercise testing. Probably even there they use more it for the heart transplant patients or lung transplant patients. And it is less time consuming than the cardiopulmonary exercise testing. This is, I think, one of the Dr. Havertz's paper about the 6-minute walk test in children done in UK, and the values I could see are almost like adult values, and we should have a reference range for depending on the age in our each clinic and correlate how our children are doing. And there is a paper from Germany which says that their children values are similar to British children. And when you are talking about collaborative research, it's a very simple thing. If you can have half a dozen centers across the country and just generate what are the normal 6-minute values in the school-going children, healthy children, that will work as useful data. And as you know, 6-minute walk test, not only based on the disease condition and the age, it also very much depends on the height and weight. So as the height and weight change, the 6-minute walk test is likely to change. So it should have to, I suppose most of you are aware of how to do, or you will be practicing, you supervise 6-minute walk test in your clinics, but just for those who are not aware, you should have an appropriate corridor length of at least 30 meters. There should not be less movement of people, very difficult in Indian situation. There should not be any obstacles. Patient should be comfortable. It should be unencouraged test. There should be a trained person supervising, preferably at the same time of day in relation to food and medication. Check pulse rate, blood pressure, pulse oximetry before and after, and keep a record on check of the progress, and box scale should be used. These are some of the fundamental 6-minute walk test requirements. Those of you who have done clinical trials would know how important or relevant it is. Now, when you look at the 6-minute walk test, what is important for prognosis is what is the baseline 6-minute walk test or achieved 6-minute walk test. For example, somebody who has improved from 6-minute walk test from say 150 meters to 250 meters with treatment may appear very good, that is very encouraging, the patient has improved, but still his prognosis is bad. Because REVEAL registry has shown us that a 6-minute walk test of about 380 meters and above, some people say even 400 above. So higher the value, better it is. And even there may be improvement with treatment in 6-minute walk test, but it's very important to achieve the higher value, which will have a better prognosis. And cardiopulmonary exercise testing is more objective, and it correlates well in children who have got more than 300 meters exercise tolerance, but in less than 300 meters, the objectivity will be, the correlation is less. But the CPEX, the cardiopulmonary exercise testing, is more reliable, more objective, because but at the same time in children, when we are doing the clinical trial, we realize that it also depends on the patient's mood. Children tend to have labile moods and they may not be doing so well. Whether it is CPX or cardiopulmonary exercise testing or 6-minute walk test, one has to keep it in mind. But having said that, cardiopulmonary exercise testing gives more objective criteria like peak oxygen consumption and VE by VCO2 ratios, which give about the pulmonary dynamics and all. Now, this is not available in most centers, so we will not discuss much about it. Then we come to the biomarkers, which are easily available. The biomarkers, the common biomarker that we use is the BNP and the NT-proBNP. NT-proBNP has a longer half-life and appears more relevant. The other biomarkers also are useful, like troponin, etc. But practically most of the people use the NT-proBNP. But again, they are relevant. They are based on it's one size doesn't fit all. You know, you have normal values vary depending on the gender. I mean, depending on the age. Yeah, this is a table which I copied from one of the journals, and here you have the normal ranges which should be useful in deciding about your therapy. And this NT-proBNP levels correlate very well with the 6-minute walk test and also functional class. You can see it very clearly. So there is some subjectivity in assessing or assigning the functional class or performing a 6-minute walk test, but NT-proBNP is much more objective. So I think there is a role for it to be used in our day-to-day practice. And if you want to look at the predictability of NT-proBNP in prediction of the death, it works one of the very fine area under curve. The value is about 0.94. Very rarely we see such a value. And compare that with uric acid or norepinephrine levels, it's much superior. So in terms of the predicting the mortality in these children, sick children, NT-proBNP is very useful. Now the question is raised about the serial cardiac catheterizations. In India, we many times wonder, even the first cardiac catheterization, there are many people who say, no, it's not required, not warranted. Maybe they have a case. But if you are seriously pursuing a child patient, and are deciding whether to go for expensive therapies like heart-lung transplantation or epoprostenol therapy, or you want to consider balloon-atrial septostomy, and you want to know whether the child is doing very well or not, whether there is a clinical discrepancy. In all these situations, cardiac catheterization can be done. I don't know in children, I can't say much, but in adults, we do from the cubital vein or jugular vein, and it's almost like an outpatient procedure. After it can be done very simply, much simpler than doing from a femoral route, and after a half an hour, 1 hour observation, you can just send the patient. The same may not be applicable in children. You do repeat catheterization whenever there is a clinical deterioration as assessment of treatment effect. It's a part of clinical trial. Detection of the early disease prognosis, and if you want to list a child for transplantation and predicting the prognosis. And one word about nearly 30 to 40% of the children with idiopathic pulmonary hypertension are positive acute vasodilative positive. It's much higher than in adults where it is only 10%. So not all children who have got positive acute vasoreactivity initially will sustain it. So if you are following a patient, if you find that patient is not improving as much as you expect or actually deteriorating, it is worthwhile repeating a repeat vasodilator challenge. And even while taking calcium channel blockers, you can do it along with nitric oxide or epoprostenol or iloprost, and you'll know whether that vasoreactivity is persisting or not. So what are the pediatric determinants of risk? This is slightly from the adult parameters. Most of them are there. The lower risk will be, they'll have no clinical evidence of heart failure, there is no progression of symptoms, there is no syncopal episodes, growth, they tend to be normal up to their Z scores, and WHO functional class will be 1 or 2, and BNP will not be much elevated. Echocardiography parameters would not show severe RV enlargement, RV dysfunction, or pericardial effusion. The hemodynamic parameters, has the paper authored by Dr. Sheila Havath has pointed out, the hemodynamic parameters are slightly different from adult hemodynamic parameters. A child with more than 3 liters per cardiac output, mean pulmonary artery to mean systolic artery mean pressures ratio less than 0.75, and acute vasoreactivity, they tend to be having good prognosis. Whereas low cardiac index, high PA to systemic pressure ratio, high right atrial mean pressure, higher PVRI, they are all markers of poor prognosis. And whenever the patient comes, you routinely, the baseline, you do all the tests. You call the stable patient once in 3 to 6 months, depending on the condition. Most of the simple things you can repeat them, including echocardiography and 6-minute walk test. Simple laboratory tests can be performed. Whenever the child is deteriorating, you can choose to do the other tests as and when required, including cardiac catheterization. So having said this, it is recommended to evaluate severe PAH patients with a panel of data derived from various parameters. That is the level of the recommendation class 1. And it is recommended to perform regular follow-up assessment every 3 to 6 months, class of recommendation class 1. Achievement and maintenance of low risk profile is recommended as an adequate treatment response in patients with PAH. You should aim for this. This is a recommendation class 1. And as a compromise, when you can't achieve very low risk, at least go for the moderate risk. That will be a class 2A recommendation. And what are the important summary of prognostic markers here, adverse prognostic factors? NT-proBNP, the risk ratio, hazard ratio is 3.2. WHO functional class 2.7. Index PVR 1.3. Mean right atrial pressure 1.1. Cardiac index, higher cardiac index, better prognosis. Acute vasodilator challenge is a better prognosis. So you should take these simple things into consideration and decide whether the child is sick or not. So when you look at the one slide, I actually did not show the ESC guidelines 2015, which is basically for adults, which categorize as low risk, intermediate risk, and high risk, and there are nearly a dozen parameters there. It's not necessary that one patient will fit into all the parameters on one side. So you have to use your clinical judgment, and you can say broadly, patient condition is stable and satisfactory, stable and unsatisfactory, unstable and unsatisfactory. So when the patient is stable and satisfactory, you are happy, just continue what you are doing. Stable and unsatisfactory, think of additional therapies. Unstable and unsatisfactory, you have to be aggressive. So some discussion has taken place about upfront combination therapy or sequential therapy. This is one of the old slides. If the patient, periodically you start one medication, follow the patient, look at their exercise tolerance in terms of whether it's cardiopulmonary exercise testing or 6-minute walk test. If the oxygen consumption is more than 10.4 ml per kg per minute, if the blood pressure is maintained on exercise, if the 6-minute walk test is more than 380, you are okay. If you have not achieved the goals, you can start the additional therapy. For example, in this patient, the patient was started on bosentan, is an initial improvement, but over a period of time there is a deterioration, then you add sildenafil. But now we know that upfront combination therapy, as has been shown earlier, is much better than sequential therapy whenever. But one thing, in AMBITION trial, the primary endpoint is driven by hospitalizations but not by death. So you will not lose a patient if for some reason you opt for sequential therapy. This is relevant in India, where patient sometimes may not afford to buy both the medications. The cost will increase. So it's okay. You can start with one medication, give full dose, follow the patient closely, and if he shows deterioration, you can add second medicine. You will not lose a patient. Hospitalization may worsen. And you should look for PAH complications. I don't know how much we see it in children, but in adults, personally I have seen all of them. Pulmonary artery aneurysms, pulmonary artery thrombosis, left main compression, hemoptysis, and arrhythmias. This is a patient with long-standing PAH, aneurysmal PAH, developed in situ thrombosis, and these people are prone for ruptures and hemoptysis. A left main coronary artery can get compressed and produce anginal symptoms and sudden death in these patients. And follow-up care should include exercise, vaccination, counseling about elective surgery, anesthesia, counseling before airline travel, central line infections in those who are on central lines. And you have to coordinate with the school staff. This is important. We don't have to do it in adults, but children go to school, and the teachers and community should know how to deal with them, and the psychosocial support. And follow-up care, probably other speakers will be talking about it: bilionatal septostomy, pot shunt, heart-lung transplantation, palliative care. So in conclusion, patient need diligent follow-up. Echocardiography is useful but has to be used appropriately. 6-minute walk test is useful, but one should know the limitations. Assessment of BNP may be a better choice. And development of PH expert centers is useful, because some of these things cannot be practiced in individual. This being a rare disease, an individual practitioner may not see many patients. So it is better to have a PH centers in tertiary care hospitals also, so that we have a proper follow-up of these patients. I think that's the end of my talk. Thank you so much.